Hello, my name is Dorothy Mills Gregg, and I'm the managing editor of Inside CMS, which stands for Centers for Medicare and Medicaid Services at Inside Health Policy. And I'm looking forward to leading a conversation today about the new set of reports from March of Dimes that show where you live matters in terms of your ability to have a health pregnancy and birth. A little bit about me: I cover Medicaid, maternal, and children's healthcare at Inside CMS. Before joining the Inside Health Policy team in 2020, I wrote stories on veterans healthcare and politics in California. So the report Where You Live Matters, Maternal Care Deserts, and Crisis of Access and Equity is a new set of reports that finds more women are struggling to access care before, during, and after their pregnancy journey. March of Dimes' Maternity Care Deserts report has been released every 2 years since 2018, and combined with this latest analysis, they represent some of the largest body of research of its kind on the state of maternity care in the United States. And data is at the heart of this new set of reports that paint a picture of how women access care in this country. These reports find that more than 5.6 million women live in counties with no or limited access to maternity care services, forcing families to find new ways to get the care they need. To help understand the reports and how this data can bring about change, I'm excited to be a part of this conversation with two women from March of Dimes who have been instrumental in the creation of these reports. That is Ashley Stoneberger and Kelly Hubbard. Ashley currently leads the Perinatal Data Center at March of Dimes. Ashley is an epidemiology graduate of the University of Michigan School of Public Health and has over 12 years of experience in maternal child healthcare research. And Kelly researches, analyzes, and writes and reviews maternal and infant health policies. As a maternal near-miss survivor and a parent of NICU alumni, she advocates for policies at the federal and state levels to improve health outcomes for all moms and babies. So let's dive into this conversation and learn some more about your report. So I guess to begin the conversation, what does it mean to live in a maternity care desert?
That's a great question because we hear the term maternity care desert in the media, and it's really become quite a buzzword lately. It all started in 2018 when March of Dimes published the first report on maternity care deserts, which they defined as a county that had no obstetric providers and no obstetric facilities. So over time, as we release more iterations of our report, we've incorporated more data sources in there to make our definition better. So when we talk about birthing facilities, what we're talking about is birthing centers or hospitals with obstetric units. And then when we're talking about obstetric providers, we're talking about obstetrician, gynecologists, midwives, and family physicians who deliver babies. And what people might not realize is in the United States, 30% of women live in counties that are defined as maternity care deserts, which is quite high.
So these maternity care desert reports are some of the largest body of research of its kind on the state of maternity care in the United States. How is this particular report different than maybe ones you've done in the past?
Yeah, so these are a lot different. So previously, we've done one national level report that looked at mainly maternity care deserts. And then it also provided information on the geographic distribution of obstetric providers and birthing facilities. This year, we have 52 state level reports for the 50 states, Washington, D.C., and Puerto Rico, that not only present data on maternity care deserts at the state level, but we also provide a lot of information on other factors that impact a woman's access to care. This year, we've also included family physicians into our definition of maternity care providers. And we did that to give a better look at providers that are able to deliver babies. So these are family physicians who reported delivering babies. So it just really gives you an idea of, especially in those rural areas where it might be a family physician who's delivering babies, where there's still issues in access. And then finally, my team is really excited to share special reports, which we created this year, which dive deeper into issues that women living in Alaska, Hawaii, Puerto Rico, and Washington, D.C. have, and also provides the data at a different way in order to be able to see that. For example, in Washington, D.C., we presented the data by ward so that you can see variation across Washington, D.C.
How does a report like this come together?
So I'm really glad you asked that because obviously I could talk about data and reporting all day. But in an effort to not put the audience to sleep, I'll try to just summarize quickly how this report came together, at least for my team. So first I want to say that this March of Dimes team put such a tremendous effort into creating this report. It was over 8 months of solid work from multiple teams across the organization. And I just want to acknowledge my perinatal data center team who put their heart and soul into this report for the last 8 months. Believe it or not, this report started as 5 aims or study questions that were agreed upon with our report funder. And then after those aims were defined and all of them were agreed upon to give like a large breadth of what are the factors that impact women's access to health. And so once these aims were agreed upon, the data team went to work in identifying data sources that they could use to answer these questions. After we identified the sources, we of course had to acquire them. So that was a process that took several months for many of the data sources. What people might not know is that every page in the report required a totally different statistical analysis. So after we knew how we were going to do it, we developed an analytical plan and we met weekly, but more likely daily, to talk about all these issues that came up while doing the report and to make analytical decisions. And then at the same time, we were working with our report contractor, PRI, who helped us design the look and the feel of the report and to also automate the report. After we had all the data analysis planned, we had to review all the scientific literature to write the text sections of the report. And then finally, after consulting with maternal infant health experts outside of March of Dimes to really provide some context around the data that we were seeing, our reports came together and we compiled all the data for the 52 reports. After that, we still weren't done because we had to do quality assurance on all the reports and make sure that everything looked right after it was automated, that all the data was in the right spot, that all the text was correct. A process that took several months and a lot of headaches. But after all that was done, the reports were ready to go live.
What does this data illustrate that we wouldn't have known otherwise?
Yeah, so previously when we published our reports at the national level, we provided a lot of information on maternity care deserts across the country, but we never took a state by state look at what was happening. So not only in these reports are we presenting data on maternity care deserts for each state across all the United States and Puerto Rico and Washington, D.C., but we're also including really rich data on other factors that impact a woman's health. So these are things like the distance a woman has to travel to their closest obstetric hospital. So sometimes a woman will live in a county and it will be a desert, but she's right on the border. So she can just drive right across that county border to get to the closest hospital. So there's maps that give you a better idea of where in the state do women have to travel the farthest to reach care. We also present data on community level factors and how they impact a woman's ability to receive adequate prenatal care. And we look at that within the BIPOC community, so Black, Indigenous, and people of color. And so you can really see where women, for an example, are living in areas of high poverty. Does that impact whether they're able to receive adequate prenatal care? Another thing we look at within the report is the availability of family planning services, so Title X clinics, which are services that people can go to receive things like breast and cervical cancer screenings and contraceptives. Another page of the report focuses on chronic disease and how that relates to preterm birth. And then finally is the policy section, which Kelly has been speaking to, which provides a state level information on the telehealth policies within the state, and then also program and policy innovations within each state.
With all these states listed in your report and the variety of data points that you looked at, what was most surprising to you or what stood out to you?
So I personally think a lot of the findings in the report are surprising, but most of all, I find it surprising that we live in a country that spends so much on health expenditures and there's still women dying of preventable pregnancy related causes. I think it's surprising that even with mortality and morbidity on the rise, we still continue to see hospitals that can offer life-saving treatment closing their doors, and a provider shortage across our country. As far as the report goes, it was really surprising to me to learn that there's women living so far from birthing hospitals in our country that they have to travel hours to a nearby large city weeks before they deliver a baby to be able to receive the care they need. I was also surprised to learn that over 10% of women in the United States live more than 30 minutes from a birthing hospital, which in some situations could mean life or death in an obstetric emergency. I learned that in Texas, there are only 3 Title X clinics for every 100,000 women of reproductive age, which is 6 times fewer than women in California have access to. And that really puts them at risk for not being able to receive the care they need, like breast and cervical cancer screenings and contraceptives. I didn't realize that over 30% of women in this country start their pregnancy with a chronic health condition, and this puts them at risk for poor birth outcomes, including preterm birth. And that in some states in this country, over 56% of women have one or more chronic condition before they start their pregnancy. And then finally, I was surprised to learn that in some states, in areas where women are living in poverty, there is a 25% rate of inadequate prenatal care compared to the US rate of 14.5%. So those are some of the things I find surprising. Kelly, what do you think?
I think from a policy perspective, for the telehealth measures, I was most surprised that more states did not make permanent the telehealth flexibilities that were made available during the COVID-19 public health emergency. While 43 states and DC did pass some permanent changes to telehealth, only 27 of the states permanently extended coverage for the 3 modes of telehealth we measured, which were video, remote patient monitoring, and audio only. I was also surprised at the number of innovative programs and policies that address access to care in states. 19 states had healthcare workforce programs to expand and diversify the healthcare workforce in rural and underserved areas. 4 states had programs to support emergency obstetric training for hospitals without labor and delivery services to save moms that were in emergency situations. 3 states used the Project ECHO to connect patients in primary care or obstetric care offices to high-risk maternal fetal medicine providers through video. And they also used Project ECHO to provide remote trainings for physicians in rural and underserved areas. Delaware provides coverage for women up to 2 years postpartum. New Hampshire directs more state funds to hospitals that retain their labor and delivery services. And South Carolina provides low-interest, long-term loans to rural hospitals to keep them open.
That's especially important when at least 8 out of 10 maternity care deserts have a high percentage of women with one or more chronic health conditions. Why is it important to address those chronic care conditions?
Yeah, so it's important to address those chronic conditions so that every woman starts their pregnancy as healthy as they can be. And some of the chronic conditions that we included in the report are things like smoking. So if a woman is smoking before pregnancy, it's a really great idea to address that so that they can start their pregnancy without exposing their infant to that toxinogen. Addressing chronic illnesses helps with healthcare costs. It will help a woman have a healthier pregnancy all around so they don't develop other chronic conditions that can stay with them throughout the rest of their life, like diabetes. And it just helps the baby have a better outcome.
Why is it important? You looked at these factors among others. Why is it important that you include all those depths of issues that women and children are facing?
I think it's really important to look at chronic health conditions because they impact such a high proportion of women who are becoming pregnant, and it puts them at much greater risk for negative outcomes. Not only just preterm birth, which we highlight in the report, but also just negative maternal morbidity outcomes. So it puts a woman at greater risk of having hypertensive disorder at the time of birth, which costs a lot of money and results in a lot of a really large proportion of maternal deaths. I think another thing that's really important to look at is what are these social determinants of health that are causing women to have chronic conditions before they have a pregnancy, and to really dive deep into the drivers of what's happening there, which we again highlight in our report. So those are some things. Those are some things that we look at that I really think are important for reviewers of the report to think more deeply about what is causing these chronic conditions and what are the community level factors that we can change to improve health.
You had a lot of data points within there. How can this data drive policy changes in local communities?
Public health data is essential in driving policy change. The data provides a snapshot of what's actually happening in the community and allows us to identify public health issues or to measure progress on public health issues we're already monitoring. So these quantitative measures help build support from community members, policymakers, and stakeholders for new policies and help provide accountability for previously enacted policies.
So, Kelly, why was it important to have policy be such a substantial piece of each state's report?
So the report identifies areas with limited or no access to care, while also providing policy solutions to address and improve access to care in those areas. We didn't want to just point out the areas of concern. We wanted to provide action steps for state and federal policymakers, community members, and stakeholders to engage in and advocate for policy solutions in their states.
And what were some of the innovative programs that surprised you or really stood out to you?
19 states had healthcare workforce programs to expand and diversify the healthcare workforce in rural and underserved areas, meaning that they incentivized healthcare workers to serve in those areas with loan forgiveness or low interest loans for their educational loans. 4 states had programs that supported emergency obstetric training for hospitals without labor and delivery units. So if a hospital didn't actually deliver babies, but a mother came in with an emergent situation into their emergency room, they would know how to stabilize the woman and provide the care for the emergency and buying her time to get transferred to a nearby hospital that was appropriate. 3 states used Project ECHO to connect the patients from primary care physician offices or obstetric offices to high-risk maternal fetal medicine providers, meaning while they're sitting in their primary care or obstetric office and having the nurses and doctors there take vitals or measure various things about the pregnancy, the high-risk specialist was there via video and could offer expertise. Delaware provides coverage for women up to 2 years postpartum. New Hampshire directs more state funds to hospitals that actually retain their labor and delivery units. And South Carolina provides low interest, long-term loans to rural hospitals to help keep them open.
So, how can people find out about their own state's care and where we're at in it?
I think one really great place to find information about your state is to use the March of Dimes Peristats website, which is an online database of all different health indicators. You just go on the website, select whatever you'd like to look at, and it will give you great information that you can use for advocacy, for writing grants, and to just learn more info about your state. So besides that, you can look for data on your state website, your state health department website. The CDC has a ton of information about all different factors related to health. You can look at your maternal mortality reports if your state has a group that reviews your maternal deaths. That's a really great place to learn about why women are dying, if there's certain risk factors in your state that differ from other states. And you can also use the HRSA, the Health Resource Services Administration's Maternal and Infant Health Mapping Tool, which is a really cool place to just see maps of different health indicators across our country.
To learn more about your state's maternal and infant health policy landscape, you should check to see if your state has a perinatal regionalization program to make sure that pregnant women and babies have access to appropriate levels of care. Also, make sure that your state has a healthcare workforce program to expand and diversify the healthcare workforce in rural and underserved areas. And finally, has your state extended Medicaid postpartum coverage? from 60 days to 1 year. We know that is essential in making sure that all women have access to care.
There's been a lot of states getting on that bandwagon. I know sometimes CMS didn't even find out until the state tweeted out that they were going to extend it to 1 year postpartum. Are there some more positive changes that you've seen? I know this report saw what was it? 70 additional counties have been classified as maternity care deserts. But what are some of the more positive changes that you've seen?
So I think some states will look at this report, or readers in states will look at this report and say, hey, our state's doing pretty good, because there are a lot of states across the country who don't have any maternity care deserts at all. So that means that they're doing a great job with having enough hospitals and providers to care for those in their state. They could be doing well on some indicators and not as well on others. So that will give states a place where they can focus their attention and area where they can improve. I think Kelly can speak to some really cool things that are happening when it comes to policy. If you want to do that, Kelly.
Sure. I think the first step is obviously to look at the data and then determine if your community is in a maternity care desert, what policies or programs are already in place, such as telehealth or maybe mobile health units to address access to care. If your community is not in a maternity care desert, are there areas within your community with underserved populations? Meaning, does everyone have the same access to care within your community? And if not, how can you advocate for policies and programs to increase access to care for everyone? Help increase the healthcare workforce in those underserved areas.
Now, we've talked about telehealth. Could you, for the people at home who maybe aren't, having as much experience with some of the telehealth applications, what does that include? Does that just include like a face-to-face interview? Does it include a blood pressure cuff that you take home with you?
Telehealth is healthcare delivered using technology to replace or enhance in-person care, and it saves lives by providing high-quality care for pregnant and postpartum women. Women who are underserved, vulnerable to poor health outcomes, and those that have limited access to high-risk care will greatly benefit from telehealth. In this report, we focused on the three most important modes of telehealth for pregnant women: video, remote patient monitoring, and audio only. Remote patient monitoring allows physicians to use technology to monitor patients in their own home. This technology can detect blood pressure changes or other warning signs to signal that the mother or baby may need immediate treatment or emergency services. This monitoring alleviates the hurdles of transportation and travel time to care for moms in rural and underserved areas. Audio-only telehealth is essential for parents who cannot easily access the internet or cellular data plans that allow video calls to their providers. In areas with limited technology access, telehealth can only be delivered in an audio-only format. And these are the patients who most often need telehealth, since they usually live in the most remote areas requiring the greatest travel time to access care.
Now, some of those stakeholders will probably be listening to this webinar right now. What are some things that they can do moving forward as a result of this report and try and make change?
Sure. I think the first thing that he or she can do is to advocate. We want you to call your decision makers, your policymakers, and the leaders within your communities, your state, and even at the federal level to implement new policies that put the health of moms and babies at the forefront. And we need you to take action today. Go to www.marchofdimes.org/MCDR for Maternity Care Desert Report to learn more about the maternal health crisis and help drive these solutions forward.
Kelly, for the people who are in maybe Alaska or Washington, D.C., how can they find out more about their state's overall effect of maternal and infant health?
Sure. So from a policy landscape, they can look at our report, obviously, and then they can search their states or their cities' policies for programs such as telehealth of perinatal regionalization and healthcare workforce expansion and diversification programs.
And they not only can find out more data, in addition to the reports, data that you guys present, they can also try and affect some change as well, correct? What are some of the things that you would hope that listeners or policymakers would try and put in place?
I would ask that the community leaders, the state and federal policymakers implement the new policies that moms and babies and put the health of moms and babies first.
This is such interesting information and data you guys are presenting. One more time, where can people find this information online?
So people can visit marchofdimes.org/MCDR to learn about the maternal health crisis and how you can help drive solutions.
Well, thank you so much for all this information and for having me here today and hosting the discussion.
Thank you so much. We really appreciate this opportunity.
Yes, thank you for allowing us the space to talk about data and policy.